who couldn't attend live. So as I always mention, if you can't attend live and you're watching the replay now, depending on when you're watching it, if you have any questions, just comment in the Facebook group on the post, and then I can definitely answer some questions, because obviously if you're not live, then you can't ask the questions, right? So just ask me questions anytime. This is definitely a lecture that you need to pay attention to, and there is some memorizing involved. So everybody can see my screen okay, right? I'm pulling up the chat box. Please send me a message if you guys have questions during our session. We're going to get started because it is 10 o'clock, 10 a.m. Eastern time. There's a lot to go through, and I want to make sure that we go through everything with you guys. But speaking of which, does anybody have any questions from our last session? Like any questions, or just any questions in general? May, hi, how are you? So nice to see you. Happy Sunday, you guys. I can't believe it's Sunday. I've had the past week off. Well, no, sorry, almost 2 weeks off now. No, a week? Oh gosh. When did I take my time off? I've still been working, but I've been working from home because of my new puppy. So I took the 11th off. So, oh my gosh, almost 2 weeks. I can't believe it's the 22nd. Like, you guys, where does the time go? I'm telling you. Where does the time go? Yes, it's so nice to have you. Thank you for hopping on this morning. So let's go through anesthetic. There's no questions so far. Type in the chat box if you have any questions. You don't have to wait until the end. Thank you for the reminder. Yes, I did click record. I actually just made sure. Yes, I did. Okay, perfect. So let's go through the lecture today. Let's talk about anesthetic and what you need to know for the exam. So anesthetic unit as a whole talks about pain management, talks about injections, talks about nitrous. So we're going through a little bit of everything. So anesthetic is just basically, again, talking a little bit about everything, and I'm going to teach you guys a little bit about everything, because you don't have to know a lot about everything. You just have to know a little bit about everything when it pertains to the exam. So let me talk about, or let me go through what I'm talking about. So they are going to ask you about the history, so the pain, because what's the point of giving local anesthetic? So just a little review here. Topical anesthetic is just meant to numb nerve endings for when the needle goes in. It's not going to actually, you know, your tooth isn't put to sleep. That's what local anesthetic is for. So topical just numbs up to 2 millimeters underneath, so above, underneath, so that the needle going in isn't as painful. That's what topical is. Local is more of a systemic, but why do we do it? Because we don't want our patients to feel pain. So just kind of a quick recap on the different types of nerve cells. You do have to know that there's a unipolar and a bipolar nerve cell, and also the multipolar. So honestly, I hate to say it, but they've asked this question on the board exam before. What are the types of nerve cells when it comes to pain management? So that's why I had them highlighted for you. I wouldn't have thought you would have to study that, but they've asked that on the exam before. So I just wanted to highlight that for you. Is everybody okay so far? And please keep in mind, everybody's pain tolerance is different. As we all know, like I might be able to handle more pain or less pain than you can. But all in all, when you're drilling into a tooth, you're into the nerve endings, it's going to cause pain. That's why we give local anesthetic. I love this image here. So they don't typically have images like this on the board exam anymore, but they might ask you questions such as, where is the myelin sheath? You know, you don't want to say, oh, it's right around the dendrites or it's right around the nucleus. No, it's more along the lines of towards the axon terminals, that kind of thing. So it's kind of good to look at the images too, just in case they do ask you a question that you might not know word for word from the slides, but you'll be able to recognize it from the image. Next one. So resting nerve cell membrane. Super boring. That's why I have an image for you guys, just in case you prefer to study it that way. So basically, you need to know these different things. I know, I'm sorry, but it's true. So membrane potential. So basically, those electrical charges that tell our nerves what's happening, there's different ones, okay? And that's maintained by this sodium potassium pump. And depending on how much can pass through the cell membrane. So that's what number 2 means, okay? Number 3, again, they're talking about the sodium potassium pump here. That's just how the nerves are conducted. So as I'm reading this slide, I'm kind of explaining it to you guys in a different way because I don't feel like you have to memorize this slide. So this is slide 5. You don't have to memorize it, but I put it in here for those of you guys who learn a different way. You might need to see how it is in the textbook when we're talking about resting nerve cell membrane. You might need to see how they would word it in the textbook, but then I'm explaining it to you in a different way. So basically what you need to know for the resting nerve cell membrane is there's electrical charges that goes across the cell membrane, and that has to do with the sodium potassium pump. Sodium and potassium. So K is potassium, Na is sodium, but it depends on how easily they can pass through. That's basically all you have to know for that, to be honest, okay? But again, I left the full words in here in case for you, when I'm explaining something, you're kind of like, oh, I don't really get it, but let me read the slide. And then you might say, oh, now I get it. So that's important. So let's move on to the next one. So continued, okay? So basically, no, there's nerve impulses always happening. So there's an all or none law, and that's what I have highlighted. So either the nerve fires as strongly as possible or it does not fire at all. So nerves aren't those like electrical impulses, the nerves, they don't like take their time, they're there. So that patient is going to feel the pain. If the local anesthetic doesn't work, they're going to feel the pain right away. Not, oh, I think I'm feeling a little something, like as the dentist is drilling. They're not going to say, oh, I can kind of feel a little something. It's not bad. They're going to go, holy heck, what did you just do to me? If the anesthetic doesn't work. So that's kind of what that means. So basically, they talk about a minimal threshold stimulus that can excite the nerve. And that depends on how permeable the cell membrane is, so how easy things can pass through. So you should know that sodium enters the cell and the potassium, it diffuses to the outside. So that's that sodium potassium pump that I showed right here. So remember how I said from slide 6. So the sodium enters the cell through that cell membrane because that has to be permeable, and potassium goes to the outside. So this is just a way to kind of show that too, if that's easier. For that to happen, you need to have ATP, which is energy. So let's talk about that. I believe it's in the next one where they talk about ATP. Okay, sorry, maybe it's the next one. But so basically, we're still talking about the same thing here. So repolarization, I don't think they've asked about repolarization in a while. But again, read through these things so you're able to recognize if something like this comes up on the exam. So repolarization basically occurs after reversed polarity. The membrane becomes hyperpermeable to potassium and impermeable to sodium. So the polarity is reestablished. So what that means is the membrane allows the potassium to kind of go through, but then the sodium, they kind of say, no, we don't want that to go through anymore because it's interchangeably. So action potential. So basically, so many things are changing. So negative, positive, and just different stages, okay? So depolarization is the reverse and repolarization is what we just talked about. So when the membrane really likes potassium, but doesn't like sodium anymore. This is where that image comes into play. So I bet I put you all to sleep, right? With just talking about that. I put myself to sleep. It's boring. But look at this image. This is my favorite. So you have 1, 2, 3, and 4. So you have the resting state, so no ions are moving. Then you have 2, depolarization is when sodium is flowing into the cell because sodium comes in. And then repolarization is when potassium is going out of the cell. But then you have number 4, which we talked about. The hyperpolarization is caused by potassium is continuing to leave the cell. So it just keeps on working. I want you guys to know this diagram because if they ask you a silly question about some of those things, that will really help you. Anesthetic is something you do need to read the PowerPoint a few times to really understand it because it's kind of boring. But the good news is they don't ask a lot of questions like this on the exam. They do ask more if you're in the States. So if you're taking the exam in the States, know this full PowerPoint like the back of your hand. It's 38 slides, know the entire thing, and you'll be fine. Okay, something to memorize. But I hope I didn't put you guys to sleep for that. There will be a mock exam question session next time to kind of see how much you guys retained for this anesthetic unit. And then I can help to re-explain things, whatever you don't understand. Because I know it's not the most exciting. But guess what? We're mixing it up. So it's a little more exciting now. So you guys are going to laugh at me, but you need to know these. So this is slide 9. You need to know the properties of a carpule. And you need to know the properties of your syringe. They ask you silly questions like that. Somebody told me on the last exam for dental assisting, they asked what the harpoon was. And this person had never heard of it before. They're like, I don't freaking know. So see, you need to know these things. I had highlighted something very important. The larger the gauge number, the smaller the lumen diameter. So the larger the gauge number, the smaller the needle, basically. Does that make sense? So you do have to know that. I gave you guys some other things to know that are directly from your textbook. Study these 2 diagrams. You do have to know them. Okay. Next one. So I just kind of explained them a little further for you because in the images, you might be saying, okay, like, what is this pointing to? What's going on? So I'm not going to read these out to you, but I do explain them further. This is slide 10. The Board Exam Prep Academy members, you will have this full PowerPoint. If you're in the Express course, then please take a picture of this because I want you guys to know it. Because you do not have the full PowerPoints. You have access to the session recordings for a certain amount of time, but you won't have the full PowerPoints, but just as well, because you can take a picture if you need to. So something to go over. Please make sure to know this slide. They've asked questions like that on the exam. Documentation. So this is a very common question. So if you've never worked in a dental office before, or you've never assisted a dentist before, maybe you worked for a dentist who did all the notes themselves. So then when you're working somewhere else where you're taking the notes, you might not know what to do. So you need to know. So these are the notes you need to take. In the real world, are these notes taken like this? No, but this is what they want you to know for the exam. So you need to write down the time the anesthetic was administered. That doesn't happen in the real world, but that's what they want you to know. You need to write down the type and percentage of the drug, the type and ratio of the vasoconstrictor, the amount of drug administered, the name of the injections, and the reaction to the drug. So all of this you will find in, oh, sorry, guys. You'll find on your carpule, okay? So see how it gives you the percentage, it gives you the name, the epinephrine. You need to put all of that down there, and you will get that from the carpule, because if a patient has a reaction, it's going to be to the anesthetic, right? It's not because the dentist injected the drug, or sorry, injected the needle not right. It's the anesthetic they're having a reaction to. So you should know what type of anesthetic was used so it's not used again, you know, that kind of thing, right? Or the opposite. Let's say the patient says to you, that was the best needle I've ever had. I didn't feel it at all. It put my tooth to sleep right away. Like the dentist before has had trouble freezing, you know, so that's good to know. So whatever that dentist used works for them, and that patient should know that so they can tell another dentist if they decide to leave the practice or whatever. So that's why documentation is key. How it works. So again, this is a little more exciting kind of, but okay. So allergies, this you have to know for the exam. Esters. So do you guys remember the two different types? There's amides and esters. So you do have PowerPoints inside your course, more anesthetic PowerPoints where I go through exactly the different types, okay? So amides and esters. If on the exam they ask you what's more prone to an allergic reaction, it's going to be esters. Okay, does that make sense? So, and there's different types of esters too, as I mentioned in this slide here. So that's why it's very important to document and pay attention to any allergies that the patient might have. So how does it work? So these are just some things that you should know. So basically, how do local anesthetics work? They prevent that cell membrane from allowing sodium to come in, because remember the sodium potassium pump, how the nerve cells are working, the nerve impulses, sodium goes in, potassium comes out. Well, it doesn't allow sodium to come in, so that nerve impulse can't happen. Does that make sense? So properties of local anesthetic, you should know this. They've asked this on the board exam before, especially are local anesthetics hydrophilic or hydrophobic? Does anybody not know what hydrophilic means? In fact, can somebody tell me, what does hydrophilic mean? If you don't mind typing in the chat box, that would be fantastic, just so I can see if we're on the same page and make sure I'm not putting everybody to sleep. Okay, so, and remember, anesthetic is acidic. So just a little side note for you here. If a patient has a tooth infection, quite often they have to be given antibiotics before that tooth can be worked on, probably from a large cavity. Maybe they need a root canal. But typically they need to get rid of that infection first, because with local anesthetic being very acidic, if a tooth has an infection, well, that's going to be acidic too. Like there's inflammation happening. The anesthetic won't work properly. So we kind of talk about that a little bit later, but so that's kind of where that comes in. Okay. Yes. Thank you. So, hydrophilic means they like water. Local anesthetics like water. Water soluble means the same thing. Okay. Free base, fat soluble. So depending on the type, there's ones that maybe don't love it either, and they're more fat soluble. So this is kind of where I talked about before. So the solution in the cartridge, so the anesthetic, is predominantly acidic. So 3.3 is on the acidic side. 6.2 is more neutral, but it's still not neutral. It's still under 7. So once injected into a basic tissue, so the mouth, the gums, whatever, that's when it starts to penetrate, like starts to work. So that's where the acidity and the basic levels come in. We explain more in a little bit because I don't want to confuse you guys too much, but read through this again and it will start to make sense for you. And we do go through the mock exam questions next time, because I wanted to give you guys time to prepare, time to study for anesthetic. Okay, so when inflammation is present, so this is what I was talking about. So basically the pH, there's a decreased level of pH, which means more acidic. So when you're injecting the anesthetic, it doesn't have a chance to really work its magic because it's also acidic. So it's going into an acidic area. It's not going to be able to work its magic. It's not going to be able to work properly. Does that make sense? If there's swelling, what's a sign of inflammation? Swelling is a sign of inflammation. So the anesthetic will have a hard time going to where it needs to go, or it might be stuck in that area of the inflammation, but it can't go to the nerve properly because it's stuck in that swelling. So it's not helping. There's increased vascularity. So what that means is giving the anesthetic, it might normally last a half an hour, but in this case, it's going to last 10 minutes because there's so much inflammation, there's so much acidity happening. I highlighted this, but I'm actually going to unhighlight it. Basically, it just kind of talks about fibers. If you wanted to read into it further, they don't ask these things on the board exam really, but it might help you understand kind of what I just said. So I just kind of have that there for you. So read it over if you want, but basically, if there's swelling, there's inflammation, which means acidic. Anesthetic is acidic, so it's going to be very acidic, and it's not going to work properly. Okay, toxicity. So this is important. So the amount of drug capable of causing an adverse reaction in a normal person. So the body is absorbing the anesthetic more than it really should. So please remember, and I'm going to highlight this in red, true toxicity happens immediately. So if a patient goes home and calls you the next day and says, I had a horrible reaction due to your anesthetic, it caused me to pass out that night. No, that type of reaction would happen right away. Something else caused them to pass out, so they shouldn't yell at you, that kind of thing. So just know that. They could ask that on the board exam. When do true toxic reactions occur? They don't occur the next day or the next time the anesthetic's given. It occurs right away. Some other things that you might notice, okay, so what's starting to happen that could lead to a very bad reaction is if the patient just changes, like they start talking a lot, they're really anxious, they start seizing. Well, that's an obvious, that's not good. Cardiovascular effects. So I want you guys to know the different phases. There's a stimulation phase and there's the depression phase. So this is when they're being overly stimulated. So their heart is being overly stimulated. The blood pressure goes up and their pulse is very fast. But then the depression is when the heart really slows down. It can't pump oxygen properly. This is where low blood pressure comes in, and then their pulse drops. It could cause death. That is something you have to know. You need to keep them alive, for lack of a better word. Like if this is happening, you can't just leave them alone and hope for the best. You have to really, that's a medical emergency. So I just thought I'd make a note of that. By the way, does anybody have any questions so far? Sorry, I'm just having a little drink here because my throat's getting dry already. No? Okay, perfect. So as I talked about before, topical is just used prior to injection for comfort. It's not needed. I'm personally sensitive to topical anesthetic. I always thought I was allergic to it, but there's no, it's very rare to be allergic to topical, but apparently I'm sensitive to it. So I don't have topical because it's the topical that actually makes me sick. But that's it. So topical is just meant for comfort. So except for lidocaine, which is xylocaine, all other topical anesthetics are esters, which kind of makes sense for me. So remember how I said ester anesthetics are more common for allergy. Esters aren't common to be used in local anesthetic, but for topical, that's just what they are. They are esters because they're just placed lightly to numb the area. That's it. So I want you guys to know the different types of anesthetic, okay? Does anybody not know what Orachix is? Let me know. I think you guys have it in the States too. So lidocaine and prilocaine are just different types of gels. This is Orachix. So Orachix is a topical anesthetic that is administered just underneath the gum line prior to a cleaning if your patient is sensitive. Orachix is amazing. It does really help them. They don't necessarily need a local that's more systemic. They can have a topical, but it's better than using the topical gel on the gums. Orachix is just better. Feel free to look it up if you're not sure, but I don't see any questions, so I think we're good. Acetacaine is a combination of benzocaine, butadiene, tetracaine, hydrochloride. So this is usually a spray topical anesthetic. That's what I've seen but apparently it can come in a liquid and a gel form as well, just different types of topicals. Again, it talks about esters have a greater incidence of allergic reaction. So amides are good, are better, but topical is so common. So give it a try. That's just basically what they're saying. So topical is just made for comfort. It's not systemic. You guys take a picture of this PowerPoint. In fact, I'm tempted to take a picture of it. Slide 18, in fact, I'm taking a picture of it so I can post it on Facebook for you guys. See, I'm taking a picture of it. I could do a screenshot. I guess that would make more sense. But anyways, so, okay, I can't explain this anymore because I've never had to calculate the dose. I don't care to. Math is not my strong suit, but you need to know this for the exam, okay? Just, I have an example here for you. I made sure it's the right answer. It's from the textbook. Study this, slide 18. They might have this question on the board exam. It's very silly because you'll never have to calculate the dose, honestly, but they like to make things hard for you guys for the exam. So slide 18, please know the calculations. I can't help you with it. I'm sorry, because I'm not good with math. I'm being totally honest. But if you just practice, or don't study it. I don't know. It's up to you. I don't want to say don't study it because it might be on the exam, but it's tough. I couldn't explain this any better. Okay, I love this chart, you guys. So it tells you the generic name. Typically, if the dentist says to you, can you set up lidocaine carpules, lidocaine cartridges? They're not going to use the brand name. They're going to use the actual generic name. Okay, so I thought that that would help you guys. And the typical concentration of vasoconstrictor, which is epinephrine. Vasoconstrictor is epinephrine, if you weren't sure. So just kind of look at this chart. The main things you have to know, you guys, is the generic name. So make note, the generic name, brand name, the color code, concentration. You need to know the vasoconstrictor. You need to know the concentration of vasoconstrictor. The onset of action can't hurt, but they're all very similar. Maybe just remember that the Marcaine, the Pevicaine, so same thing, blue, takes longer to start working. That's a good thing to know. Toxicity, I don't think you have to know toxicity, you guys. You can if you want. And that's it. Feel free to study the whole thing, but what I just mentioned is going to be on the exam, probably not the other things, but it can't hurt to study the whole thing. It's up to you. This is slide 19. So vasoconstrictors is is epinephrine. So basically what that does is it helps to make the anesthetic last. Does that make sense? And epinephrine helps to limit bleeding as well. But epinephrine can speed up the heart rate. So if your patient tells you they've been sensitive to anesthetics before, they're really nervous, you might want to use one without epinephrine so you're not telling their heart to speed up. But the ones without the epinephrine don't work as long, but that might be good. Your patient might like that. So just a little side note on vasoconstrictors. I talk about it a little bit, how vasoconstrictors work, and that's what I have highlighted here. They increase how long the anesthetic is in there for. So if you're doing surgery for 5 hours, you want a vasoconstrictor. You want that anesthetic to really work. You might have to re-inject halfway through, but if you're doing like a 30-minute procedure, you're not going to want to pick an anesthetic that has a vasoconstrictor life of like 6 hours. No, that won't be necessary, right? So there's different types for different things, for different procedures. So basically, this is what you should know as well. So once it is absorbed in the body, the action of epinephrine is terminated primarily by the reuptake action of nerves, and then epinephrine kind of leaves the body and is inactivated by enzymes. So I didn't read this whole thing because blah, 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 boring. What I want you guys to know once epinephrine, so I'm going to say it again. Once epinephrine is in the body, it's working, but then it immediately just escape. I mean, sorry, not immediately, but when its shelf life is done inside the body, it's just going to leave the body. Like it's just going to, the enzymes break it down. So the patient won't have that in their system for like 6 days, just for when it's needed. So they don't need a ride home. They don't need any of that, because vasoconstrictors just do its job and then leave. So that's all that is saying. Continued, again, you guys, I have some calculations for you. I'm sorry, I can't explain them any further, but to determine if a carpule is going to be toxic, how much do you give them? This is what the dentists do, okay? If you're a dental hygienist and you're allowed to give anesthetic, I'm not, where I live, we can't. But if you are, then you do have to know the calculations. But you probably learned this in school, so you're pros. But definitely know that if in your state you can give local anesthetic. I cannot where I live. That's just probably why I haven't cared to learn it. Again, I just kind of go through everything for you, how to be safe, how much to give the patient. Injections, you guys, so different type of techniques. So the main thing I want you guys to know, I'm not going to read through this whole thing. The main thing I want you guys to know is there is basically a nerve block and infiltration. So I am going to highlight this. So the injection, the infiltration, depending on what textbook you read, they call it different things. That is where you're injecting the needle at the site or a couple sites over, like if you want the anesthetic to work on 3 or 4 teeth. But a nerve block is like half the mouth. Half the mouth. A nerve block, you don't do nerve blocks for the maxillary. Those are typically just infiltration. So a little side note, you can infiltrate maxillary, mandibular, it doesn't matter, but typically a nerve block is done if you're working on the lower teeth, just because it's just easier, because there's so many nerves in the lower area. That's why they do the nerve block. Fewer injections. So infiltration means you have to inject more times, because it's typically above that tooth, like all the way up here, not here, but like all the way up. What's the word I'm going for? Like past the attached gingiva, all the way up there at the apices. Sorry, that's what I was thinking of. At the apices, that's where you inject for infiltration. I have charts inside your course where I kind of show you where things are injected. Look at that. But yeah, so, and the nerve block is typically the retromolar pad area, and that does the whole half the mouth. So the nerve blocks and infiltrations are different. Does that make sense? So I explain it more here in the PowerPoint. I don't have to go through it. Feel free to read over it. But again, the infiltration just means more injections. The nerve block is typically just 1 or 2 and freezes half the mouth at a time. So I kind of go through this a bit. These are the nerves that you need to be thinking about: the ophthalmic branch, the maxillary branch, and the mandibular branch. I talk about that more inside the course too, so definitely have a look. But this is a basic review of things you need to know for the exam. So this chart I love, and this was the chart that I was referring to. So the different types of injections, okay? So, and this actually tells you what they are. So if you see ASA on the exam, that stands for the anterior superior alveolar block, okay? That's what it stands for. And that just basically means it is freezing a large area, okay? A large area. If you were doing infiltration, you would be freezing like every tooth or doing that injection for every tooth. And then another one, for example, the GP stands for the greater palatine block. Okay, so if you guys can't tell from the picture, this is why it's divided into the left and right side. Because let's say you're doing teeth over here, you would put the needle point along here. It's not going to freeze this side too. It's just the one side on these teeth. So that's why it's kind of divided into different sections. But the nasopalatine block up here, that is the one that's given directly like behind your incisive papilla. Does everybody remember what the incisive papilla is? Nikita, hello. If you have questions, tell me, because I know you're just getting started. So please tell me if you have any questions. This might be a bit over your head, okay? I don't know if you've looked into anesthetic yet, if you've looked into the anesthetic unit. If you haven't, this might be over your head. I apologize. Okay, so Nikita, is this over your head? Probably. But you know what? When you do learn anesthetic, it's going to actually tie in much, much better for you. I am happy that you did attend the session today, because you can kind of get an overall, and then when you do take it, you will feel better about it. You might not notice you feel better about it while you're relearning it in class, but then when you go home to study it again, you'll be so quick at studying things because you'll have already learned it in a different way. I explain things differently than your professor will. So actually, Nikita, quick, can you send me your course curriculum so I can see what you're learning, like what topics when you're learning it? And I can definitely switch things around, because how I do the sessions are, you guys tell me what you want to learn, because in our 2019 sessions, our 2020 sessions, if there's a topic you want to look at first, click that, and you can hear me lecture. You can hear me do a mock exam on it. So any new session that I have, it is based on what you guys want me to teach you. So Nikita, let me know. Send me your course curriculum by email, and I can kind of plan things that way. I don't mind doing that. And I'm sure other people would be very happy too. So please let me know. Anyways, you guys, so this is a great chart. Print this chart, okay? I'm telling you. Yes, send me the courses you have for this semester. Yeah, sorry, that's what I meant. I think I said curriculum. Same thing, kind of. But yeah, please send me that so I can help you and I can kind of not make things so over your head. So sorry. And anesthetic, even if you did learn it, it's going to be over your head anyway. This is something you have to relearn all the time. Even I have to, because I don't use this stuff in my practice because I'm a mobile dental hygienist. So even me teaching it, I'm like, oh yeah, what is that again? So don't feel bad. So you're going to be tired after this class. I'm sorry. Over your head for sure. I'm so sorry. Okay. Anyways, I like this chart too, you guys. So I have different charts for you. Oh, sorry. I didn't finish my train of thought. I apologize because I don't think I did. For the nasopalatine block, that's the one that's the most painful. So if on the exam or test, so if you're a student still in school, you're not taking the board exam anytime soon, it kind of still applies. Your professors are going to have the type of questions that I'm kind of telling you guys to focus on, okay? They're probably going to have more because in school, you're tested on every single section, whereas the board exam, it's not every single section of anesthetic, it's the overall, right? But nasopalatine block is very painful. I haven't had it, but I've seen like 30-year-old men have tears in their eyes when they're giving the anesthetic because it's brutal, apparently. Another chart to help you. Nikita, you will have the PowerPoints as well. I kind of, okay. Nikita, send me an email with your courses. I'm going to email you today also. So send me an email to remind me to email you how to study prior to your test, okay? Because it's a bit different for you since you're not studying for the board exam. Actually, there's a couple people in here that aren't studying for the board exam, but you're studying for your class exams. You will study things differently. So please email me so I can remind myself to email you to talk about that. Anyways, computer controlled local anesthetic devices, I've seen it. Not too many people use it. It's just basically they turn something on and it's supposed to be an easier anesthetic. It's not supposed to hurt, but you're probably spending $20,000 on this stupid machine. But I wanted you guys to know what it was in case they ask it on any test or any exam, There is such a thing as a digital local anesthetic device. It just kind of helps to increase comfort. That's all. That's all. Another chart for you. I can't make it any bigger, but if you guys click on the PowerPoint, like you can make it bigger if you want. It's just basically telling you guys all the different causes of what can go wrong when it comes to local anesthetic. I'm not going to read them out to you, but you do have this inside your course. Okay, so you do have this. I'm going to actually take a picture of this again. Sorry, guys. I'm going to post it in Facebook for you just to remind you. So that way, sorry, I'm taking a picture. I probably look, it's kind of hard to see, shoot, but you might be able to zoom in better. Or when you're watching the replay, click pause and you can zoom in, right? I think, so try that. Okay, quickly for nitrous oxide and oxygen, all I want you guys to know is nitrous oxide is not a painkiller. So you don't do nitrous oxide or local anesthetic. Nikita, this will probably be more like not so over your head, okay? So nitrous oxide is used for sedation. It's to make the patient more comfortable, but they're okay to go home afterwards because once they turn off the nitrous, they give them full oxygen, they're back to normal. Like they're like, hey, what's up? Once that nose piece is taken away. So nitrous oxide is sedation. It's not a painkiller, meaning they still need local anesthetic to to put the tooth to sleep. So the nerves aren't awake, if that makes sense. Is everybody okay with that? So nitrous oxide is the blue cylinder, oxygen is green, okay? If you're working in an office, they will walk you through this. But nitrous is blue, oxygen is green. You have to know that. They love to ask that type of question on the exam. I don't need this image on there again. So I just kind of talk about how it's stored, no big deal. Nitrous has no effect on the heart rate, blood pressure, liver, kidneys. Just make sure to give them full oxygen afterwards. You aren't responsible for that. The dentist is. Some dentists want the assistant to be responsible for it. They want the hygienist to be responsible for it, but no. And they're not allowed to actually. Depending on the state you're in, they might be allowed to, but like here, we're not allowed to touch the nitrous or the oxygen. Is everybody okay with that so far? The physiology of it, again, it's just basically saying the same thing that I talked about. It helps to calm the patient down. They feel better about everything. They can tolerate what's happening better. But local anesthetic is still needed to numb the nerve. If you just give them nitrous and drill into the tooth, they're going to feel it. Ouch. Just, you know, like nitrous doesn't work that well. You still need local anesthetic. You need to know the different stages of anesthesia. Okay, you need to know this. This is when we're talking about general anesthesia, when you're putting the patient to sleep. Okay, so you need to know the different stages. You need to know the names and what's happening. Memorize this entire slide here. Slide 35. I'm taking a picture of it. Memorize this entire slide. Take a picture of it. Save it on a folder of your phone. They're going to ask this question. I feel like I've explained it pretty well. If you look at the different stages of anesthesia in your textbook, it's probably 3 pages long. You don't need to know 3 pages long. Know the basics, know what's happening. That's it. So obviously the respiratory paralysis is death, you know, or they're dead. Sorry, that sounds horrible, but you know what I mean, right? So you need to know these things. Okay, next one. Indications. So basically, why would you give them anesthetic, basically? Why wouldn't you? This is talking about nitrous. Sorry, I should be more specific. Nitrous. Even I had to think about that. Like, what am I talking about? Nitrous indication. So why would you give nitrous? Why would you not? You know what, you guys, I kind of want to take this out because some of these are old school. Sorry, guys, I'm taking that out. So never mind. Forget it. So color-coded tanks, no blue for nitrous, green for oxygen. There should be an alarm system. So when oxygen is starting to run out, there should be like your nitrous tank or like oxygen should have a beeping sound, because you don't want to be giving the patient nitrous and then going to use the oxygen and there's none left. You need oxygen with nitrous. That's the safe thing. So there is usually an alarm system, or you have to check every time. So I hope that helps. Some extra resources. If you guys wanted to learn more and put yourself to sleep, these are kind of the resources that I had used for this, because this isn't something that I'm just teaching you from my own knowledge. This is directly from a textbook. So how are you guys doing? Is everybody okay? Our next session, in fact, no, I don't have to write that down. Yes, I do. Our next session is going to be the mock exam questions on anesthetic. Okay. And for those of you who are still in school, not preparing to take the board exam, but just you wanted as much information as possible while you're in school, tutoring. Don't look at mock exam questions until you've studied the material. Otherwise, you're going to get kind of upset, because you're going to feel like you don't know anything, and then you're jumping right into the mock exams. Okay, so that's why I try to title all of the videos either mock exams or lectures, so you do know which is which. So for those of you, if you haven't had a chance to study anesthesia, for our next session, I'll be doing the mock exam questions on that. You might want to not pay attention unless you want to learn anyway. That's completely fine. It can't hurt, but just realize, don't feel bad if you don't know any of the answers, if that makes sense. You guys, we finished in really good time today. Look at that, because I try not to keep you guys so long, because I know it's the weekend, I know it's Sunday, but we did pretty well today. So does anybody have any questions? Are you guys okay? Fallen asleep yet? I kind of feel tired, because this topic is boring, isn't it, you guys? I'm sorry. Good question. Do we have our next sessions yet? You guys know me. I have the worst memory of anybody. Let me check. So to look at our next sessions, they are under the events tab in the Facebook group. And no, we don't. So I am going to make a note. I usually do the sessions a month in advance. So I will have the September sessions up very soon. I'll let you guys know. They're typically mornings, but sometimes they're evenings too. I like to mix them up, because I want you guys to have a mix, because depending on where you guys live, I don't want you to have to wake up super early or stay up super late, depending on when it is. But a lot of you have said you prefer evenings, and then some of you have said you prefer mornings. So I can't make everybody happy. I do try to mix it up, but thank you guys for those of you who came today. It's nice that I'm talking to students and not just talking to myself. It's kind of nice. I know. Yes, you're so welcome. You're so welcome. I hope this didn't put you to sleep. I'm going to have the September sessions up probably within the next few days, because I need to check my schedule as well, because as you guys know, I see patients. So I want to make sure that I have everything prepared for you guys, because you guys are more important. Patients are too, but you guys come first, always. So I definitely want to do that for you, but I don't want to book it in when I'm seeing patients, right? So I just have to double check that. But you guys are so welcome. Thank you for coming. Have a great Sunday. Please post in the Facebook group anytime, and I'll talk to you guys very soon. Okay? I will probably be posting some more videos soon. Yes, please send me the email. That's so perfect. Thank you. Thank you, guys. Have a great Sunday. Bye for now. Bye, guys.